All right. Here we go. You ready, Chris?
I'm ready.
All right. Well, everybody, thank you very much for coming. So this is our first ever one where we're actually doing the traditional version of having the split screen and everything like that. So this is really weird. So we're going to have to do one in person at some point, Chris. But
yes, we will.
Okay. Well, thank you very much for joining. All right. So we have a lot of stuff to go through. You have had an unbelievably interesting life and are crazy humble about it. Like a lot of people who have gone through, it's funny because a lot of people who complain about adversity typically haven't been through as much as the people who don't complain about it, because I feel like you get weathered over time from things and you might not think it's that big of a deal, but you've had a very interesting life. And we're gonna go through your career, what you've done for helping out vulnerable populations, which is just probably kind of like a bit of a reoccurring theme here, but we'll get into the thick of how we get things to where we want to get them for the future. We're going to get to that later. I want to really kind of get people to know a bit about who you are, because you're an awesome person to have in the industry, someone who I've only known for probably not even 10 years yet, probably about 8 or 9 years.
Even more. We're getting older.
Yeah, speak for yourself. I mean,
way back when MACRA and MIPS first came out. When was that?
When what came out? MIPS?
When MACRA legislation first came out, we were thick as thieves.
Right.
I mean, we've gone back a while.
Well, I mean, like all the quality stuff didn't start until 2008, I think, was where they had PQRI, which turned into PQRS. Then meaningful use and all that fun stuff.
Oh my goodness.
All the different headaches that all of our people in our industry know. And these are all things that were designed to improve quality. So, and again, we're going to talk a lot about this stuff, because I think, there are a lot of people out there, and you and I chatted a little bit about this yesterday. There are so many people out there that are like, oh, I want to help out vulnerable populations. I care about the poor. I care about, disparage, like I care about minorities, I care about this, I care about whatever. But like everybody says that, but not many people walk the walk. And that's one of the reasons why I wanted to bring you on, because you have walked that walk extremely well. And I think what I want to get into is how you got to that, because it's not like you are a traditional story where you're like a rags to riches story, that you weren't raised in poverty, although you've lived in some interesting areas. So
I have.
Yeah, you've lived in places that a lot of people would be beyond the worst of what people live in here. That so this is going to be a lot of fun. So let's get started. I want to just throw out a couple disclaimers here. Oh wait, do I have any banner? I think I made a banner. I have a new thing here where I have like this little ticker. Everybody hates when I do things like this. So I get a little bit of feedback from people, and they're like, stop putting labels under things, and this stuff is annoying. But here's some contact information for you and a little bit about you that I'm just going to scroll under there. Maybe I'll do it later, but again, I'm sure everyone's going to tell me that that's terrible and to stop doing it. But we're going to get into, I've had way too much coffee. I'm drinking out of my my Britney Spears. See this? Single taking mentally. I don't, what do you got? And you're always happy, yeah. So I want to start with, we've got to get the story of your son started here. So let people know. I've heard this story, but I'm going to turn this over to you. Let people know a little bit about where you came from and what happened in this situation.
Sure. So, my son, who is now 29, going on 30, when he was an infant, had all kinds of health issues and, had interception, where he, just all kinds of guttural issues. And we noticed at about 8 or 9 months that he really liked to line things up. And so I would ask my family members, hey, is this the way it goes? Like, he would have a little barnyard, and he would line all of the animals up. And if we changed compartments of where they were at, he'd go right back to the figurines and put them right back in the order that he had them. And we were like, this is really interesting. You know, our son's really interesting. So fast forward, being a toddler, he was back in those days diagnosed with pervasive deficit disorder.
Yep.
And which is now just, you know, on the autism spectrum, but back then that's just what they called it.
Mm-hmm.
And we, you know, just through the years, a lot of the care coordination, it just didn't happen. And kind of like stories that you hear about today. So I had about 7 or 8 different notebooks, all different colors, for like all the different specialists, all the different care providers. And then, you know, I would write down, and then I was like the communicator between all the different care teams.
Yeah.
And one of the things that I noticed, a lot of the care that he needed at that time was not covered. And so we happen to have, you know, just really gracious grandparents, and, you know, who just put tens of thousands of dollars of their own money into the care in order for him to close a lot of the gaps that he was experiencing. And so for me, I just had this thought to myself, well, wait a minute, what happens if I couldn't afford that? Or what if I didn't know how to access it? Or what if I didn't know how to navigate the healthcare system? You know, I was like one of those true like bulldog, you know, advocates for my.
How old were you at this time? About?
I was 25.
Okay.
But I mean, I was like, you know, at that time, I owned my own company. My family's really entrepreneurial. So I had a translation company that I worked a lot in healthcare and in, you know, in the court systems. And so I was like, I am going to figure this out. And so, you know, I thought to myself, what if I couldn't have afforded it? Like, this doesn't seem fair access to care. Like, he's getting, you know, these really great specialists, and a lot of the great specialists at that time didn't take insurance. It was like they had so much business, and they were like, we don't need insurance, you know. And so that was one of the things that influenced me to say, wait a minute, something's off here. And you know, fast forward all these years later, my son is a Navy nuke and he's doing really well. And again, I have to ask myself, would he be a Navy nuke? Would he have graduated from college? Would he have done all of these things had he not had that early intervention? So that was kind of, you know, personally something that really impacted me to say, I want this for every kid, not just in the United States, but everywhere. Like, I really love children, and I was like, this isn't right. Something's wrong here. Something's broken.
Okay, so 2 questions on that. One, well, I guess first question is, what is a Navy nuke? What does that mean?
So he works for the United States Navy, and he works in their nuclear department. And so, you know, a lot of the submarines, the ships, they're run by nuclear power. And so they call them Navy nukes.
Okay. All right.
It fits him to a T. Now, I don't know exactly what he does. I don't tell me, because a lot, you know, he has top security clearance, so he doesn't really talk about his day. I know that's what he does, but, you know, I don't really know what that means.
Well, so it's interesting because you're talking about tens of thousands of dollars. So obviously the vast majority of people do not have funds like that. And in our system, the way healthcare works is your plan is not just created by your doctor, but it's also approved of by your insurance. So we had a couple of weeks ago, we had Dr. Siva on, and he was talking about how, like, sometimes the patient will come back like, I thought we had an agreement that we were going to get this treatment. Why is my insurance company say we're not doing it? He's like, I still agree we should do this. But you get stuck in these situations where the payer has to approve it. So now your plan, what you think is best for your child, even though you're paying for your health insurance, is now not approved. So you have to pay money out of pocket. And a lot of people face things like this. And in your situation, thankfully you're able to afford it. And then you look at this in a way that's basically, how many people have a son like mine that are being left behind, right?
Well, and not only that, I was also in a situation where I put, during those early days, I did a lot of side gigs, because I would say a good portion of my day, really all the way through until he was in middle school, was spent on just advocating for this child. I can't tell you, just all the self-advocacy, all the advocacy that went into helping him in school, and to what I call like educate some of the educators, because at that time they were just like, why is he doing this? Why does he have to eat a certain diet? They didn't know a lot about the autism spectrum then. Yeah. And so I would be like, trust me, you do not want to give this child sugar. You will not like the result. And that actually, I think in his second grade class, he accidentally ate a cupcake. And his teacher said for the rest of the day, he literally was like bouncing on the ball. And no matter what she said to him, it was like he couldn't even hear her.
Really?
And so those were why I had some of those dietary, implementations, and they thought, oh, she's just being a helicopter mom. And I'm like, no, really.
Well, I also don't think that that's an insult when someone's a helicopter parent. You should care a lot about. It's funny because now there's a lot of I was talking to somebody who may end up being a guest here, who was talking about how allowing like risk to kids is now good, because we basically are trying to almost raise them in rubber rooms to protect them because we love them so much. And because of that, you have people taking selfies sometimes on the edge of a cliff when they turn like 20 and they're falling off because they've never been hurt. They've never had the consequence of their actions and stuff. I mean, I was always a kid that had to touch the oven to know that it was hot, but so this is, I don't know. Yeah, it's kind of wild. So like I think especially with autism, it still is not even close to understood. So we've seen in the last just couple, I mean, you're talking about 20 years ago, my oldest daughter was just diagnosed earlier this year. And the information that I'm getting is awesome, because I can now finally understand things like, they have all these terms that you might not even be familiar with because they're probably more recent, like autism burnout and things, where it's like how they manage things during the day and how there needs to be like rest afterwards because of the process, how they process items and how society works in certain ways. And there's so much that I've learned to understand, distinguish between laziness and autism burnout and stuff like that. So
I do remember as a child, and he was very particular. He would carry a briefcase to school and even in preschool. And he would come home, and, a lot of kids on the spectrum, they'll flap. And I remember he was very articulate. I'd say, oh, why do you do that? And he was like, oh, it just, makes me feel better, calms me down. And so I'd be like, okay, well, so we would have designated times and places where he could flap. So right after school, he was exhausted and he would go straight into his room. And that was his time where he could kind of flap in his room and then calm down. And then he would come out and get a snack. So we would have, within the school, I would have like break times in his schedule, kind of so he could decompress. And so kind of some of the things that you're talking about really made a difference. And then it kind of got me in the journey of behavior change. How do you change one's behavior? Because there were a lot of gaps, performance gaps that we needed to close. And that kind of started my journey in performance improvement, because I was like, well, if I can, change on an individual level behavior by doing different things with my son, how can I translate this into organizational behavior change and, kind of take that outward? So that kind of got me really interested in performance improvement, quality improvement, organizational change, and managing that. So it actually translates rather nicely.
Well, so when we talk about disparities, and we'll get deeper into the United States, but I didn't know until yesterday that you had actually lived overseas for some years over in Jordan. Are you all right if we chat about that for a minute?
Yeah, let's do it.
I mean, I imagine those kind of health disparities are things that are just, we can't even imagine here what healthcare is like in a place where access, like we talk about access here. Like I'm frustrated with a lot of things, like in Massachusetts alone, we have like the Kearney Hospital got shut down because of the irresponsibility of the Steward healthcare system. We have, and honestly, Steward Healthcare, they shut down Quincy Medical Center prior to that. They acquired it, and this turned it into basically like a functional extension of the emergency department over at from Kearney. So, and you talk about vulnerable populations. I mean, I did a lot of work over in Dorchester, and I mean, they're like when we were doing work with their emergency department, that was the first time I was dealing with like gunshot victims and stabbings and things like that. Folks there need emergency care, and they do not have it right now. So, but as difficult as we see access here, we're in a whole different world than other places. So when you were in Jordan, give us a taste of what life was like over there.
A realistic day in a life was, our family of 5. We literally, with water conservation, had about a bucket of water a day for everything. So what that meant is it changed, like we ate off of one plate. Because you don't have water to do a bunch of dishes. And we were really careful to cook out of like one pot, and then we, didn't flush the toilet if
flush it once a day or something like that
at the end of the day, and got really used to using, not putting any tissue down the toilet, and so in the life of the day, like in living in a village in Jordan, it's kind of completely different. There isn't the same infrastructure. So I remember, I was like, how do I pay my bills here? How do I, and people would just show up at the door and be like, oh, you owe this, or, at random times. And so in terms of the healthcare, I'm going to tell you the things that I loved, and then, the things that I learned, right, and then maybe some things that were really hard to see. So some of the things that I loved is, which I brought back with me, was the doctor in the village, Hassan Salida. Hello, Dr. Salida. We were really good friends with our doctor. We knew our doctor's family. We would go to their house for dinner. There was like close relationships between the doctors and their patients. So when my daughter got sick, I called Dr. Salida. He immediately stops at his clinic and he's like, I'm coming over. And comes over, takes us to the local hospital, navigates the whole system with us. So it's a much different relationship than, I have a scribe coming through the intercom and I've got like,
Well, yeah, and like our PCPs, and most people don't know this, like everyone's kind of like, oh, cool, he remembers me. He just talked about how he remembered I was going to be going on vacation this fall. And it's like, nope, that's just on their chart. They have 2,500 patients typically. And like they might recognize you from like, I know I've seen this person before, but mostly they're reading that right before they go in the room. Whereas what you're talking about, they actually know there's no way they have 2,500 patients and they know their people, like they actually know you.
yeah, or like, where we lived in the village, I didn't have an address. So people couldn't send me anything because it's like, how do you say for your address? Well, I live, with the green door by the duck house. Like, you can't really put that in your address, right? So he would be like, oh, if your family wants to send you anything, my clinic has an address. Because clinics could get address, they did have addresses for the clinics. And so it was this I started to get the feel like, oh, is this how it used to be? Where you really knew your patients and you really deeply cared for one another and families. And that was
like a member of the community and stuff like that.
it was just, that was beautiful.
Yeah.
So the challenging part, and another beautiful thing I'm going to tell you from a cost standpoint, the prescriptions were like, 75 cents, $1, the purple pill, which would be hundreds of dollars here, would be, like $1 there, in the village. And so you just go to the pharmacy and be like, hey, I need blah, blah, blah. And they would, give it to you. With saying that at the time, the average salary per month was about $60 a month. So we're putting things in perspective.
Okay.
The cost of drugs, another great thing. I was just like this is unbelievable. Like what's happening in the US? Because the cost is very manageable there. So that was another good thing. Some of the other things that were really challenging was just the condition of the facilities. So the hospital facilities, I mean, you would have like sinks falling off the wall. The walls would be kind of like brownish, like, you probably not the cleanest. And when we had a friend who was hospitalized and she was in the ICU, I was like, the tubing is brown and I think there's a fly in it. And like, there's smoking in the ICU and like, there's bandages with open stuff in it, like laying on the radiators. I'm like, I am not a clinician. I don't claim to be a clinician. You don't have to be. But I was like, okay, something like this is.
Yeah, my sister-in-law went to the DR earlier this year. She was in an accident where like a golf cart, like an ATV golf cart type of thing that they have over there. She ends up slamming her head into a tree. She has this nasty gash, which was terrible because she just got married last month. And but she said she walked in there, there were blood stains on the floor. There was a Gatorade can that was filled with, antiseptic to sterilize some of their, just things where you don't want to be in those situations, in those type of places when you actually have an emergency type of situation going on.
Yeah. So that and I can't stress enough. And then like the medication, it would be just like an open, cabinet, and you could see there were hardly no medications in there.
Yeah.
And so I remember we had to, for our residency, we had to get tested for AIDS. It was part of the law for being a resident.
Okay.
And I remember going and speaking to the Surgeon General. We talked about our families, of course, because that's what you do, right? And he's like, okay, so we're gonna bring someone in and just like, take your blood. And I started crying because I'm like, I'm gonna get AIDS from these dirty needles.
Wow. Right.
I like started like crying, and my husband's like, it's gonna be okay. It's
Oh my God.
okay. It's okay. Because like that's what I'm talking about. It's not like they, open things up and everything's sterile. So I was like, I know I don't have AIDS, but I could have AIDS now.
How is treatment for things like, if people had like disease management, let's say somebody did have something like AIDS, and how is that treated for, again, yeah, how do they manage something like that?
So I didn't work at a hospital. I worked at a bunch of schools. But from what I saw, I really don't know how. And there was also in certain tribes, right, where the women could only see women healthcare professionals.
Okay.
So what do you do if you're in an area where there are no women healthcare professionals? You just die, right? Because
Did you see that? Were there people literally just dying in their houses at times because they couldn't have access to treatment?
Yes, and not only that, this was something that was really interesting. When people found out that, I was a Christian, I don't know what their prior experience with Christians were, but a lot of the poor Bedouin who lived in tents, and when I say there will be like, 5 families and there'll be like 4 tents, they would have 2 teacups between all of the families. Like that's the kind of poverty I'm talking about. And they would say, please come have a cup of tea. And so I would travel, have a cup of tea. And then they would say, we want you to come into the tent. And by the way, can you heal our child? Because and then I would go in a tent and it would be this like shivering sick child and with no access to care at all. And they were, looking for other means since they didn't have access to medicine or healthcare. So yes, I saw that frequently, and they would say, please pray for healing, because there was no other means. And so when you first start seeing this stuff, it's pretty overwhelming, right? Because I'm like,
imagine that.
I'm not a healthcare person, and so it certainly turns a person into kind of a pretty strong advocate when you see and how beautiful and wonderful the communities are.
Wow.
So that was kind of something that happened, really on the regular. That, and people would drop off a lot of animals at my doorstep too.
Okay, we need to pick up the mood here. That's terrible. That's.
So that was like the good, bad, and ugly. But all in all, I took a lot of really beautiful things: the resiliency of the communities, their creativity, and as well as just how beautiful a personal relationship with your physician can be with the families. Yeah. It's a beautiful model in that respect.
Oh my God, yeah. There's so much. I mean, we could do a whole show just on that. I mean, even just the place and where Jordan is in the world it's such a, I mean, you can imagine things can go south quick in a place like that. And that's really, wow, that's wild.
But this is the thing. I want to tell you, I can't explain to you how the community took care of us. And I'll give you an example. The women, even though the women and men were separated, the women knew everything. So we would watch this show called Noor, which was a soap opera. And during that time, they would kind of say what was going on. So they would say,
so you had TV. Hold on, I'm sorry to interrupt, but so they only would have like 2 teacups in a house. You're eating out of one shared plate, but you guys had television?
The Bedouin. But some of the other people, if they had TVs, we would watch Noor. So I was specifically referring to the Bedouin and the poor Bedouin, because they have very wealthy Bedouin as well. But the poor tribes and the refugees. And so When I would watch, Noor, the women would say, "Oh, by the way, you and your family need to go to Amman, in 2 days' time because there's going to be, a cell coming through, and they don't really like Americans. So, like, go to Amman for a few days." So they were very protective of me because they knew I was there helping their children,
Mm.
and helping them. So there was such a sense of loyalty and care, and I can't stress that enough. That was
Yeah, I mean, I've seen stories even recently. I think earlier this year, just a few months ago, there was a story about a woman who was a reporter or something, and then there was a mob of people who separated her from the folks, and I mean, without going into more of the details, it's very dangerous for women too. And but that's oh wow, okay, we're coming back to the U.S. now. All right.
back to the U.S. Yeah.
So obviously you are armed and ready from personal experiences from not just within your family, but also with communities that you've seen some wild things in. You come back to the U.S. and let's get into your actual career now. So you come back here, and because I think I first met you at Health Centric is where you were working.
Yeah.
Is that where you started when you came back?
I came back to the US after that, and first of all, the thoughts that I had, first of all, were I live in the greatest country in the world. When you live abroad for any extended period of time, you realize, like, we have our issues, we do, but we are such a strong, spirited, resilient group, in America, in the United States. And just when we come together, there is just nothing that stops us in terms of innovation, problem solving. So that was the first thing that happened when I came back to the US. The other thing I noticed was from being in we'll say, kind of a dictator-like region, it does make you a little paranoid. So I remember coming back to the States, and I was like, why are these men talking to me? Because or what information do they want? Because if you have, the secret police coming to your door, which happened to me a number of times there, you get kind of paranoid about people knowing your business. And so the first thing that happened was, like, just decompressing from that, and saying, okay, I live in the freest nation in the world, and I can speak my mind, and so I can't tell you the stark difference in that when I noticed right away when I came back, as I was decompressing. So just a little aside. So
I mean, it's not a rare thing. Most people that I've talked to that have worked, like the conference room I have here has been dedicated to a former employee who's unfortunately passed, but she's lived in Jakarta for about 10 years, which is a very different part of the world than you were in, but still, like, they needed armed guards when they were going into certain areas and stuff like that. I mean, it's because the anti-Americanism in certain places is very legit, and same kind of thing, like, had some very positive things to say, but certainly when back here felt safe and like, almost like you're saying, like being able to take a breath of fresh air. And that's
the like heaviness, kind of lifting, that I could just freely speak. And when you're in a place where that's not the case, where you literally get thrown into jail for whatever you say, it is, and then you come to your own country and you can just speak freely. I just can't tell you what that was like for me. I was just like, I love my country. So that was the first thing. And then after I decompressed, I said, I'm very passionate about end of life care, and treating everyone with great dignity. It's something that I think since I was a child, my mom would drop me off every Saturday to a nursing home, and I would like have fun and do art projects with,
They must love that.
yeah, and I did the same thing when my kids were younger, but
Yeah.
so I started working in hospice, and getting more into the palliative care, home health, palliative care
Right.
scene. So I started off in that, and then I worked with Tarsha Weaver over at Mihai in Massachusetts, and that was back in the day with like all the EHR incentive payment programs and the rec. And her leadership was unbelievable. She was such a mentor to me in those earlier days.
Yeah.
And she brought in a ton of revenue into her division. She was powerful, and she had the most diverse workforce of any other part of Mass Tech Collaborative. And the end products and the end results were phenomenal. And and she would take me into the boardroom, and she'd be like, watch, I want to bring you in, I want to expose you to these things. So she had a great influence on my earlier career.
Awesome. Wow. So yeah, and as we get into this part of your career with the quality work, I think I should just every once in a while I have to let the audience know certain things, because we have a lot of folks that are not in the industry. So when Chris talks about things like EHR, that's for electronic health record. And for a lot of the quality metrics were items to make sure several things, like making sure that doctors need to continue with their education. In fact, a lot of folks in the healthcare industry need to get continuing education credits to renew their licenses, their various licenses. Nursing has it as well. And there's lots of different jobs. So because of that, so for instance, if you have somebody being admitted into the emergency room, they typically need to get a baby aspirin right when they come in. And if not, they have to have a reason why they're not getting it. And so that was like very early stuff that was coming in for quality metrics. And it's gone on from there. And where you come in, I imagine too, like even right now, you have certain incentives with MIPS for ensuring that, this is going to, so there's one that a lot of people use, which is, especially if you work in a facility setting, that basically says if you're, that you don't discriminate based on insurance. So, I'm just going to tell you a personal story here, or I mean, not personal, I guess it's a career story, but there was a emergency department that I managed in Massachusetts that it was very much fee for service. Everybody, it wasn't a team. They weren't on salary. Whatever they ate, whatever they made, right? So they were making crazy kind of money. There was one clinician that I remember once that was making like $100,000 a month. I mean, he worked like he was an animal. He did a lot of great medicine. He just happened to work really quickly. But you know what else he did though? Every time he saw a Medicaid patient in the list of patients to see, he would put them aside. Every time he saw a Blue Shield patient, he would grab them and be like, all right, I'm going to treat this one. And so it was funny because at one point the chief came up and he was like, I have a couple of clinicians that are terrible. They're not seeing any of the Medicaid patients. And I was like, well, there's a real obvious solve for this. And he was like, what do I do with them? I can't. He was like, everyone's frustrated because all they see is Medicaid patients. I was like, put them on the same shift together. They have to see these patients. They're going to have to see Medicaid patients. But and so part of that obviously is it's terrible for somebody to put somebody aside based on the insurance company, which I think any reason, but also the incentive, however, is
it happens. It's still happening.
Yeah, the incentive goes in the opposite direction. And I think this is the trouble with, when we talk about people getting equal care, as much as they try to blur these lines, and it's great, you want to try to create as many opportunities for folks who are on Medicaid plans to be able to get the same care as folks who are not. However, the priorities are still there for a reason, because the payouts are still less. You have a lot of practices who will not even accept Medicaid. And there needs to be, but, because doctors don't want to work for free. Nobody wants to work for free. I don't care if you're a nurse, if you're, a vendor, if you're anyone from the staff, reception or something. If you're not getting a paycheck, you're not working there. So it's, this is where the situation gets very difficult and where like the rubber meets the road as far as what we're talking about here, leveling the field. So I'm sorry, I'm jumping ahead a little bit here, but let me backtrack and let you talk for a second. So you're now getting into the part of your career where you're dealing with these type of quality matrix to try to create incentives for people to actually have equal care.
Yeah, and back in those days, I mean, they would talk about patient advocacy, but they didn't have patient family advisory groups at that time, or there weren't regulatory requirements, for example, to have a beneficiary representative on a board of an ACO, or, so I think we've come some ways, as well as some of the patient experience measures that are counting, and also in some of the value-based contracting, there is more of an emphasis on health equity and health resilience and closing those gaps of cares. So we're on this continuum as we move towards value-based contracting and employer direct contracting, and so I don't. The more I dig into it, the more I learn. But the way that I learn is just by listening to people in different communities and hearing about their experiences. And so for me, I think to myself, what does a patient really want? And of course, in the US, who wants to be a patient? Because that equates to being sick and acute care, right? So who actually wants to be a member of that group, first of all? But if we are a member of that group, what is it that we really want? And we want access to good quality care. We want it to be, coordinated, right? We want people to hear us, listen to us. If we say we're in pain, we mean it, and so I really believe moving the continuum further is all about continued transparency for cost and quality to the consumer, empowering patients and families, because patients are also the caregivers, right? That are in the families taking care of their loved ones. And so I believe we need to give them more power in the system. Their voice needs to be not just like a quality measure for patient experience. I mean, they need to be have the power and authority to drive a lot of what's going on in healthcare. So I feel like we're moving in the direction where, there's some regulatory requirements. You've got your HCAHPS, your patient experience measures, but I want to see that go further.
It has to go a lot further. I mean,
further, yeah, where the patients, we're driving. It's like, we're driving what we need and want.
Yeah, and I think patients are typically terrible advocates for themselves too. I think a lot of times, number one, they don't know what to ask. They don't understand that a lot of the care that you have is set up for a particular type of person and might not be designated to people who have what your home situation is or what you have access to or even what your race is. Like, there's different plans of care based on all sorts of different things. And what the stereotypical plan of care is going to be different for each person, and people are much more complex than what they see. And I think they often don't know what to advocate for themselves, and I think, like you're saying, being able to have some kind of advisors to help them is great. How often do people seek that out? I imagine is very rare. I don't think people really typically do that. Or, I gave an example, I think a couple episodes ago where, one of my kids got Lyme disease, and then I pushed for a full tick panel where they never even told me I should, but I had known from a friend that I had in the past that they said, if you ever get Lyme, if your kids ever get Lyme, make sure you push for the full tick panel. And if that conversation never happened, my kid would have had another tick-borne illness and potentially could have had neurological issues because of it. So if it wasn't for a random conversation, I wouldn't have known to ask that question because my provider definitely didn't say it. So I think being able to advocate when you're not a clinician is very difficult to ask for people. And, and I think that there's got to be better incentives too, like financial incentives specifically for all concerned. Like, so you see with the stuff that you did a lot of work, I think, with a lot of like 1 and 2 doc shops, right? Like a lot of the stuff that you did was subsidized from CMS to try to help out a lot of clinics where they don't have
medically underserved areas across New England. Yeah.
Right. Yeah. So rural and because hospitals have quality departments set up like this, so they know how to maximize whatever they need to get whatever kind of tax breaks or financial rewards or whatever. Mm-hmm. But most doctors, a lot of my clients don't know that stuff. So we have to bring them that education, which is why you and I met and had a great connection when we first met. So, I mean, that being said, a lot of this is dancing around because the clinicians typically do not see a lot of extra money. They're typically going to do extra work. They'll figure out a measure that is the least intrusive to their practice. Mm-hmm. So like if they work at a hospital, they're going to be like, well, I have to see all patients, so I can say that I'm not discriminating against Medicaid patients, so I don't have to do anything new or whatever. And that's fine and all, but like the problem too is that, like the federal government will come in and say, you're going to get punished if you don't do this financially. And then you come up with
voluntold, yeah.
And this is the pain point too. And nobody really has compassion for doctors, but I know the bottom line. I know how close those break-even lines can be for certain practices, and the ones that typically want to go above and beyond for their patients, that break-even gets that much tighter. And when you're being asked to do this, and we talked about this in episode 5 too, in home care, there's a lot of new regulatory pieces that just recently passed. And there's no financial incentive. So who's doing all this extra work and why are they not getting paid? Like if you're going to ask someone to do work, there needs to be reimbursement for it. And I think that's one of the toughest things with a lot of the quality measures.
I think if we kind of expand it out even further, we used to have a lot of like independent physician groups. They're kind of getting gobbled up now. But there are some models that I do think show some promise. For example, the clinically integrated models, the CINs, the clinically integrated networks.
Yep.
Especially if they're physician-owned and led, tend to have better coordinated care. And then they're able to maximize reimbursements through shared services and of the network. So I do, and I would say about 75 to 80% of the contracts in a clinically integrated network are value-based care contracts. Yep. But whether it's commercial, Medicare Advantage, and then you have your Medicare, Medicaid plans. So I do think that physician-led groups are much higher performing, we'll say.
Yeah, I think and the jury's out on CINs, but I think that because when IPAs came out, that's what we were expecting from IPAs, and I mean, PHOs never were really that model, but PHOs caught on a lot because you had a lot more business-minded folks doing it than doctors. And now with CINs, like I know in where do we have a CIN locally? Lawrence General has a CIN. Actually, one of my clients runs that. He's a chief medical officer over there, Dr. Robert Haddad. And then which I imagine by proxy might mean Holy Family now is. Which I know that they've renamed it, but like that, the old Holy Family campus, and I think the Merrimack Valley, I think fall under that banner too. So they probably all are part of a CIN now. So yeah, I mean, I agree. I'm hopeful that
in Connecticut, they're a great example of a physician, Stone Health out of Connecticut. They're in Connecticut and Mass, and they also are a clinically integrated network, physician owned and led. But what that means is, they can strike better deals for pharmacy, and they can really contain costs and offer a lot more care coordination,
Sure.
a lot better data analytics through their medical economics department. And so I do think that, things are happening that are really great. And I know my time while I was at Sohn, two executives who really mentored me was Renee Broadbent, who's the CIO, and Truman McKenna, the CFO. They really took me under their wing and exposed me to all of the departments and the whole business, and took a lot of time to mentor me. And Stephen really, he loved to teach about data and all the different models, and I just soaked up so so much from Stephen and the medical economics team. And so they were, again, a part of my journey of seeing, well, what could be, what happens if we can offer, a special program where colonoscopy screenings, you can get that in 48 hours. What does that look like, and how does that affect quality, and kind of study those trends? So, there's a lot of good stuff happening. But I will preface that with, we need the patient voice front and center, and not just telling nice stories. I mean, that they have authority and power to make policy decisions, and to move transparency even further along.
Yeah. So so this takes me right to community health now, because it's just popping in my head for a couple things. If we talk about what would we want, what I would want to do. So I know that generally speaking, Medicaid, Medicare have not been great for the country. They're money losers and stuff like that. And FQHCs, so once you get to community health centers, it's kind of a different story. So there's no one that's able to treat patients for government subsidized care in a more efficient, there's no more efficient model and better care that folks get than in a place that actually can be budget positive and not just budget negative. So people really, because a lot of people look at it as I'm dumping all this money into Medicaid, or I'm dumping all this into, and and the country suffers. And when you see these models, and as you probably know, community health centers, their board of directors is required, and I love this, to be over 50% patient. So
yes, that's what I'm talking about.
Right. So this gets to your point. So if you have that, they have to be a patient of the system. So they know what the facility looks like. They've dealt with having to get a prescription filled within their health center. They've seen the doctors. They know the wait times, how they manage things, whether it's translation issues or whatever. Right. So that is so here's one of my suggestions would be if something like the Carney goes down, the Carney Hospital in Dorchester, which is in a very impoverished, vulnerable area, very tough area, Dorchester, Massachusetts, and you replace that with a community health center. Now all of a sudden you have accountability, a better model, and here's another thing.
You do get higher reimbursement rates, and I know I'm working with a client in Erie, Pennsylvania, where we're doing their FQHC lookalike designation. And they're already doing great work with refugees and in Erie, Pennsylvania. But, to your point, that model does help bring in more revenue for the work that they're doing.
Right.
And of course, this is the thing, right? For a clinic to become an FQHC, going through that designation process, is not for the faint of heart. It's like
I don't know that process, but I'm sure it's not.
Yeah. So I mean, it takes some pretty dedicated group of clinicians to do that, and to go through that process. But yeah, I have so much respect for our FQHCs, and I'm super hopeful and excited with the Rural Health Transformation Program that the states will give, a ton of funding to our FQHCs and rural health centers. And
yeah, so I mean, so you obviously know some of the clinicians in the community healthcare center environment, and I do as well. So like, that they don't get paid what if they could go next door to an acute care hospital and get paid significantly higher. So these are mission driven people. These are the kind of clinicians that we love and want. And so, when I talk about, like earlier when I was saying things like, there's no incentive, you give us all this extra work, but at the very least, like, what if, maybe we can't afford incentives as a community, whether it's from the state, federal, or both. But why the hell can't we do something like this? If you're serving an underserved population, I don't care if you're in an acute care or a community health center or something like that, we at the very least give you like some kind of tax break. Like, so I don't care if you're a doctor, because we know even the entry level people are not paid well over there. And it's not for any reason other than the fact that community health centers they're also under a lot of pressure. A lot of them are not profitable. They all depend on grants from the federal and state government. So to get that, why don't we at least give some love? Like when I was working with Greater Lawrence Family Health Center and COVID hit, and I'm like, I was terrified. These people could quit and make more money than they're making right now. Our entry level people, you have 600 employees, 100 are physicians, but a lot of them aren't. And they stayed and they worked. And you bet your ass I gave them a bonus at the end of that. I was running as treasurer, and we got the finance department. We're like, we're going to recognize this at the end of the summer of 2020. We were like, we have the opportunity to give something back and recognize these people. We're going to do it, because the people who work at these places they're good. There's a lot of good blood in these people. And, maybe you can't always give them bumps in pay or something, but maybe at least give them something so that, like that, to inspire clinicians, or at least give some incentive or some recognition for the fact that you're taking a pay cut. You're not that you should be into this stuff for the money, but man, we could certainly benefit. I'm sure the people of Dorchester would love to have a community health center over there. The people of Quincy, who lost Quincy Medical Center, would love to have something that's right around the corner. And if it's easier to start off something like that, then why are we not doing that? Like focusing more on those, because those are and then you have these bad actors like Stewart that come in and just crap over our whole system in our state, and healthcare goes to hell.
And there's Holyoke Health Center in Holyoke, Mass. And we talk about acute care, chronic disease management. I saw a lot of chronic disease management happening at Holyoke Health Center.
Yeah.
We ran a lot of diabetes self-management courses. They were doing a lot of wellness campaigns, and as tech is growing and expanding, you have like mobile health units. You have a lot of savvy tech startups in behavioral health that are creating platforms where first responders can work with behavioral health clinicians to kind of avoid incarceration, or avoid just dropping someone off at the ED and giving them the right care at the right time. So there's new technology, and of course we always know in certain areas, right, you have issues with technology that need to be worked through community by community. But I am starting to see some more movement. And I know one of the things I was really interested in when I was in Ireland, in the rural country, I was like, how do you guys do your health care out here, because there weren't any hospitals nearby. And it was like, they would have mobile cath labs, mobile this, mobile that, that would go to the countryside to help the people. And we're starting to see that. And I do think policymakers are hearing, because part of, for example, the Rural Transformation Health Program that is going to be offered, I think they have to submit each state by November 5th, and then the federal government will let everyone know by the end of December who is going to get some of that federal funding. I do think that they're listening, like, hey, we're having a shortage of clinicians to even come out here. How are we going to tackle that? How are we going to address that? And I believe a lot of that is you're going to see a lot more SaaS startup companies and with technology enabling some of that access.
Right. Yeah. I mean, I think with tech and AI, hopefully we'll get some good gains. I think what we also need to do is have a lot more attention, especially for Medicaid programs with preventative, because like there's so much, like, I mean, we talk about things like prior auth issues and stuff like that are still in referral issues that drive me absolutely insane. I actually just had a personal one where I just recently had to change my health insurance, and now all of a sudden this new one needs a referral, and these folks even work in the same system, but because it got changed too close to an appointment, now I lost out on my appointment, and God knows when I'm going to have another opportunity to. It's going to be months before I can get that rebooked. So, and these things are frustrating for everyone to deal with, but if you have a lot more attention,
bill, and you're like, what do I do about this? I just got this, a few years ago, I got a big medical bill, and so I knew to look at my portal, look at the claims, talk to the hospital. And I'm like, wait a minute, like, you guys are billing the wrong CPT code that's not covered. You got to bill under this code and this code and this code.
Right.
But what if I didn't know about CPT codes and modifiers? Like how would the average American know how to navigate that?
They never will know that, and they get lost in the system, and that's why it's like so overcomplicated. But yeah, the preventative, especially the preventative medicine piece, like if you have any genetic history of, like, I mean, these payers, and they're not going to listen to anything until they realize that it financially helps them, which of course it does, because if you're dealing with, would you rather deal with a heart issue prior to it starting to make sure this patient is on some kind of a plan to ensure that they're going to be in better cardiovascular health than treating it when they're 50, when they're going to hell like a lot earlier than they should have been going to, and for really any condition, it's I think that's going to be another big bastion of help for people in the future for leveling that field. I think what we need to do is have a lot more attention. I mean, and this is for all patients, not just Medicaid. But I think when the reason why I bring that one up to Medicaid is, I mean, obviously that's what we're talking about today, is leveling the field. But in addition, this puts that means less patient visits. Like if you can handle something prior to it becoming an issue, or get someone on a plan, or teach them. We talked on our home care episode in episode 5 about just teaching people about basic things like nutrition. So like people are doing smarter things in their teens and 20s to prevent things from coming up in their 30s and 40s that shouldn't really be happening to your 50s or 60s or 70s, is smarter healthcare, and less visits will sit, like, if the taxpayer is worried about putting money into Medicaid or Medicare, they're going to get a better bang for their buck too. There's going to be less money taken out from these people having chronic issues at a younger age and being dealt with for 50 years for issues that they really should be only dealing with at end of life.
And there's, when we think about, you talk about nutrition, but when we look at the prices at the grocery store, think about how expensive it can be to eat healthy. And if you only have access to go, let's say, to walk to a convenience store, what kind of, healthy choices are there, and how can we look at nutrition in different environmental contexts to say, how can we learn about nutrition in our environment in a way that we can eat as healthy as we can with the budget constraint that we have, maybe access to healthy alternatives. In some cases there aren't. So if I, based on my circumstance, what can I do? And really about, that I'm all about that self-agency, about empowering people in their lives. What if we have a chronic disease? What makes us want to get better? I mean, I remember I was doing a quality improvement project on cardiac rehab, and I would run everything through our patient and family advisory group. And I'd say, okay, what do you think about this program? And here's the brochure. And they're like, this is scary. You mean you got to do all that? I don't know. And you have to exercise. This is so scary to us. The things you're talking about for cardiac rehab. And I said, well, what are your reasons for wanting to do it? And they're like, my grandkids. So I scrapped the whole brochure and it's like, what really motivates people towards, self-efficacy and it is very different than what we might think.
Yep.
The policymakers, people who are doing quality improvement. And so
Right.
that's why we have to ask. We really have
to. This is the thing about having, like how you were talking about working for someone who had, this board that was very diverse. And usually you find a lot of success when you have that. So, when you're having these boards, I think, there's so many holes. It's so easy to poke holes in things like MIPS, for instance, because there are so many specialties that seem to be just left in the dark. So you have clear focus on any clinicians, like you're talking about cardiac there, but cardiopulmonary issues, a lot of like the big issues. There are great measures that are focused on ensuring there's certain quality of care, there's certain standards, but then everyone's included. So I have physiatrists that are doing rehab medicine, and they're trying to find any measures that even have anything to do with them. They're required to be a part of this program. So my thing is if you want this, if you're requiring them to be in this program, either number one, they shouldn't be required to be in the program, period. But if there is something important that you care about for physiatry, have the American College of Physiatry, which I assume there is one, have that board work to come up with measures that are at least something that's tangible to work with, because you have people you have podiatrists. Do you care about feet at all? No. So but why are they required to be a part of this? And so you have so many specialties that are just not considered for various reasons. Some of them I would agree with, this probably isn't something that we need to really focus on as much as that specialty. But it should be conditional, like everything in healthcare, they try to do a one size fit all for regulations. And I don't envy those positions, but you have to have diversity.
To different pathways. But to your point, back in the day, a lot of the specialists, we would have them work with registries that were more in alignment with their specialty, or working with a QCDR approved company. To help level that playing field. But it was kind of, I'm sure that from a clinician side, especially if they're I'm retiring next year, this is too much,
Well, that's the thing too. You talk about clinical shortages, and I know I've had plenty of clients that have gone into early retirement. A lot of them. I was just talking to somebody last night that works at a local system, and she's not even a clinician, but she was telling me about how she has colleagues that, all of a sudden you have somebody that comes in, they start changing policy at the hospital or something like that. And all of a sudden it's just me and my colleagues are just kind of done here. I'm going to move on to another opportunity, but this person, they're going into retirement. And it's always people like you, Chris, who are these good stewards of healthcare. They're doing great work. They're in it for the right reasons. But then you have some some bully that comes in and tries to change things, and typically not for the most respectful reasons. And then these people are just like, screw it, I'm just done. I'm calling it a day. I could have retired years ago. I don't need this anymore. And then we lose good people. Okay, well, hold on. We've already gone over our time. Let's talk. I haven't even talked about what you're doing now. So now you're CEO of Mode 7 Designs, right?
Yes.
Let's at least talk about
So quickly, we build and design enterprise solutions fit for fintech, healthcare, enterprise companies. We do customization, automation type work. We do a lot of work around, you have a problem, we solve it. We build tools and frameworks and do a lot of performance improvement work. And so basically we're quality geeks. We have data scientists on the team, software engineers, Jacqueline Penn, who's the COO, is doing some great work in the Virgin Islands. We have Brian Loss, who's our CIO, who is like, I've never met a developer who solves problems in the simplest, most cost-effective way. Isn't that great? If someone's like, I'm going to solve the problem, we're going to keep it simple and not like cost a lot of money to.
Oh my God, how many times I could have used somebody like that?
Yeah, so that we're all diverse backgrounds. We're diverse backgrounds, we're diverse faiths. We come from different countries, even on the team. And the one common mission is that we like to empower organizations and companies that are helping to make other people's lives better. So building things to make people's lives healthier and happier. So that could be a tech startup or, a nonprofit, me working with a clinic to become an FQHC, or a community health worker who has her own business trying to figure out her audits. All kinds of ways that we can use technology to help people. So that's us.
I love it, Chris. And when you get back to, I was going to say the U.S., Massachusetts, this is how like egocentric Boston is. When you get back to the real place, we got to meet up too. I've started this thing where I'm doing these little woodwork. I don't know. Do you know I do woodworking on the side?
I didn't know you did that.
No? Yeah, everybody has hobbies. So I do woodworking, but I've started doing this thing where I'm making these little woodworking like ornaments for all my guests. So I got a cute little angel one for you because of your faith and stuff like that. So I'll next time when you come back, we got to meet up so I can give that to you.
So I'm going to be back in a few weeks, actually.
Okay.
So we'll connect.
Sounds good, my friend. Okay. Any parting ways? I really appreciate you coming on here.
I'm so thankful to you. I'm thankful for, nobody makes it anywhere without a lot of support. And so just for all of the people that in my life that have like provided the support, the mentorship along the way, and just to encourage everyone, it's really going to be okay. We're going to get through this, I think we're gonna be okay.
Well, you said earlier about what life is like, and that is post 2000. I think what you were talking about over in Jordan, and it's like, yeah, man, there's probably a lot of stuff that a lot of people are like, you guys are so spoiled and take so much for granted, and I think we do, but I think still it's a part of the human experience to always be striving for better. And we and as good as things are here, we certainly can clear. I mean, we've talked about a lot of potential solutions. You were saying well, Tim, there isn't a real easy solve for this, but we talked about several things that could potentially really move the needle, at least into a better direction, to try to get better care to the folks who who really struggle, so they end up like, you know, I mean, how I imagine what you're looking for is a world where everyone that has a son that was struggling like yours was, that they can take their path that they know, because everybody knows what's best for their kid, or they will do, you know, it should be up to the family's choice on what path to proceed with, and there should be assistance for that. And it shouldn't be something like, well, if you're not doing what I think is right for your kid, you're going to get cut off. We shouldn't have a system that's like that. So anyway, thank you for sharing so much of yourself, Chris. And we'll catch up tomorrow because we have some stuff we have to chat about. So I'll be talking to you soon.
All right. Thank you, everyone.
Thank you, guys.